Hello everyone. Today we are going to discuss about pharmacotherapy of open angle glaucoma. The learning objectives of today's class are introductions, risk factor of glaucoma, pathophysiology of glaucoma, drugs used in open angle glaucoma, and drugs contraindicated in glaucoma. Introductions. So the terms derive from the Greek word which affects 12 million Indians annually. So glaucoma is a chronic progressive optic neuropathy characterized by increased intraocular pressures, that is more than 21 mm per Hg, and that damages the optic nerve which a visual loss, and this increased intraocular pressure occurred due to the either that could be increased aqueous humor formations or due to the impairment in the drainage system that leading to the raise in intraocular pressures. Risk factors. So 40 to 45 year of age people are more prone for the glaucoma. Apart from this, there also will be due to the family history or due to the physical injury like eye trauma or conditions like diabetes mellitus, cataract, cardiovascular disease. So this kind of disease, patient with this kind of disease, they are more prone for this glaucoma. Apart from this, we also have certain drugs intake that may precipitate the glaucoma. That includes the corticosteroids, antihistaminic drugs. Anatomy of eye. So before starting with the pharmacotherapy of glaucoma, we'll discuss briefly about the anatomy of eye. So the part of eye which involve in glaucoma, that includes the cornea. This is the part of cornea. Behind the cornea there is a iris, and behind the iris there is a presence of lens. So the lens will be connected with ciliary muscles. So this is the ciliary muscles, and with the ciliary muscles lens will be connected with suspensory ligaments. So as I said previously, glaucoma occurred due to the excessive secretions of aqueous humor. That aqueous humor mainly synthesized from ciliary epithelium or ciliary body, and that will be drained by the iridocorneal junctions via canal of Slim. At iridocorneal, so this is the iridocorneal junctions, this is the iris, and this is the cornea. So this junctions is called iridocorneal junctions, and this is the major pathway for outflow of aqueous humor. So at iridocorneal junctions there is also a presence of mesh-like structures that is called trabecular meshwork. Here, that is in iridocorneal junctions, there is a presence of mesh-like structures that is called trabecular meshwork, which normally offers the resistance to intraocular fluid, which tries to percolate from iridocorneal angle to the canal of Slim and maintain the pressures of 10 to 20 mm per Hg. So that is the normal pressures created by this trabecular meshwork. Apart from this, we also have canal of Slim and sclera, which will come under the anatomy of eye, and that involve in the glaucoma. Drainage of aqueous humor. Aqueous humor is a major factor for precipitating the glaucoma. So aqueous humor to be drained via two routes. the major route which drain 90% of aqueous humor, that is by the trabecular network into the canal of Slim that drains about 90% of aqueous humor from the canal of Slim to episcleral vein, and that eventually drain into the ophthalmic vein. Second pathway include the evioscleral pathway that contribute 10 to 15% of the drainage process. So this include the aqueous humor drain the drainage process into the ciliary muscles, and that passes to the ciliary body, and then ciliary body to the choroid, choroid to further drain into the suprachoroidal spaces, and finally that's a scleral venous plexus. Drug targeting receptors. So before starting with the pharmacotherapy or drug treatment of glaucoma, we'll discuss briefly about the different types of receptors that present in eye and that contribute the management of glaucoma. So there is a three type of receptors here involved in glaucoma that includes the muscarinic receptors. So muscarinic receptors mainly present in the ciliary muscles. Ciliary muscles, there is a presence of M3 receptor, that is muscarinic receptors. Whereas second group of receptors, that is the adrenergic receptors. As we know, aqueous humor synthesized from the ciliary epithelium, and there is a blood vessels. So there is a presence of different alpha receptor and beta receptors. Predominantly alpha 1 and beta 2 receptor, and also there is a presence of alpha 2 and beta 1 receptor in the ciliary epithelial tissues. Apart from this muscarinic and adrenergic receptor, there are also an involvement of a postanoid receptors. So there is a two type of glaucoma. One is narrow angle glaucoma, where there is a blockade of iridocorneal junctions or narrowing of iridocorneal junctions, and because of the narrowing of iridocorneal junctions, there is an impairment in the drainage process of aqueous humor. Second one is open angle glaucoma, that is our main topic. So this name suggests open angle glaucoma, there is a opening of iridocorneal junctions, but still there is a glaucoma. So in open angle glaucoma, as we have discussed previously, the trabecular meshwork. So the trabecular meshwork get blocked or rigid, though there is an opening of canal of Slim, but due to the decrease the patency of trabecular meshwork, there is a increase intraocular pressures. So this open angle glaucoma also called as a wide angle glaucoma, as the angle is wide. That angle we're talking about is iridocorneal angle or iridocorneal junctions. It is most common with progressive painless, obviously painless visual loss, and there is a decreased patency of trabecular meshwork. It is also slow progressive raise in intraocular pressures, usually chronic type. Now diagnosis. So increased intraocular pressure can be detected by tonometric pen or tonometer. The normal intraocular pressures or reference range is 10 to 20 mm per Hg, and in case of open angle glaucoma, the intraocular pressure is raised to 22 to 40 mm per Hg. Now coming to the drug treatment of open angle glaucoma, first class of drugs include PGF2 analog, that is prostaglandin analog. These drugs include latanoprost, travoprost, bimatoprost. Beta blockers, that is second classes of drugs, include timolol, betaxolol, levobunolol, and catiolol. Third classes of drugs, that is alpha adrenergic agonist, include the dephenyphrine, apraclonidine, and brimonidine. Four classes of drugs, that is the muscarinic agonist, rarely been used nowadays, that include physostigmine and pilocarpine. And the last most classes of drugs that include the CA inhibitors or carbonic anhydrase inhibitors, that includes the drozolamide and acetazolamides. So first class of drug is prostaglandin analog, that is PGF2 alpha analog. So they are considered to be a first line drugs with a once daily dosing with longer durations of actions. So this kind of example of this kind of prostaglandin analog include latanoprost, travoprost, and bimatoprost. Mechanism of actions of this kind of drugs, they are mainly prostaglandin analog. So they act on the prostanoid receptor present in ciliary muscles. They decrease the intraocular pressures by increasing the permeability of tissue. They also increase the evioscaral outflow. They also help in releasing the matrix metalloproteinase enzyme. So matrix metalloproteinase are the family of proteolytic enzyme that degrade the extracellular matrix component such as collagen, and they are present in virtually all the area of eye and responsible for the maintenance and remodeling of ocular architectures. So they release of matrix metalloproteinase enzyme and they digest the extracellular matrix material that may impair the outcome. Coming to the adverse effect of prostaglandin analogs, which includes conjunctival hyperemia, eyelash growth stimulations, and hyperpigmentations of eye. So this hyperpigmentations of eye can be prevented by giving the drug in evening time. This drug is strictly contraindicated in pregnancy, being a abortifying agents, which can cause the uterine constrictions. So apart from their adverse effect and contraindications, they also contribute certain advantages over the other classes of drugs. These include good efficacy with longer durations of actions and once daily applications, which improve the patient compliances. Also have absentees of systemic side effects or complications. Coming to the next class of drugs, that is beta adrenergic blockers. These include timolol, betaxolol, cartilol, and levobinolol. And apart from these drugs, there are also certain drugs we'll discuss in the later. Mechanism of actions of beta blockers. So beta blocker, they block the beta receptor present in the ciliary body, which decrease the cyclic MP. So among the all beta blockers, betaxolol and timolol contributes the neuroprotective effect by blocking the sodium and calcium influx. Certain beta blockers include the levobetaxolol. They blunt the ganglionic cell death. They prevent the ganglionic cell death in glaucoma. So non-selective beta blockers, they are mainly strictly contraindicated in the asthma patient. Next class of drugs, that is muscarinic agonist, also called as a myotics. These include the pilocarpine, which is used topically, 0.5%. Mechanism of actions, activations of M3 receptor cause the contractions of ciliary muscles. As we know already, there is a presence of M3 receptor in ciliary muscles that increase the drainage of aqueous humor. Adverse effect, diminish the visions, headache, brow pain, spasm of accommodations. So next class of drugs include the sympathomimetic drugs. So adrenaline. So as I have discussed previously, the formations of aqueous humor from the ciliary epithelial involve the two kind of receptors, alpha and beta receptors, predominantly alpha 1 and beta 2 receptor. And the main functions of alpha 1 receptor is vasoconstrictions. So alpha 1 agonist can be effective as a vasoconstrictor agent which contribute the decreased formations of aqueous humor. With this principle, we're going to use the adrenaline topically, though nowadays it is not being used because of the increased cardiac complications. So adrenaline, they decrease the formations of aqueous humor by vasoconstrictions. Side effect include the or adverse effect include the irritations, pigmentations of conjunctiva. Second class of drugs, dapivirine. It is a prodrug of adrenaline which penetrate the cornea and is hydrolyzed by the esterase present in into adrenaline. So here we can see dapivirine, they get converted to the adrenaline. Adrenaline act on the adrenergic alpha 1 and alpha 2 receptor that decrease the aqueous secretions, and that in turn decrease intraocular pressures. Adrenaline also have additional actions by opening the ureteral outflow, and that also contribute the decrease in the intraocular pressures. Next classes of adrenergic agonist include alpha 2 agonist, that is apraclonidine. So apraclonidine used topically 1% as a adjuvant drug. So this is the mechanism of actions of apraclonidine. Apraclonidine act on alpha 2 agonist, or they act as a alpha 2 agonist. They decrease the cyclic AMP productions, which in turn decrease the formations of aqueous humor and help in reductions in intraocular pressures. So they decrease the IOP or intraocular pretensions by 25%. They also contribute certain adverse effect include itching, dermatitis, follicular conjunctivitis, mydriasis being a adrenergic agonist, and eyelid retractions, dryness of mouth and nose. Next class of drugs include the carbonic anhydrase inhibitors or CA inhibitors. So these all drugs have been divided into two groups, topical agents and oral agents. Topical drugs include the dorzolamide, benzolamide. Orally drugs which is used include acetazolamide and methazolamides. So as I discussed previously, ciliary epithelial actively secrete different ions like sodium ions, followed by passive secretions of chloride bicarbonate ions. So this CA inhibitor or carbonic anhydrase inhibitors, they inhibit the carbonic anhydrase enzyme in ciliary epithelium, which in turn reduce the formations of bicarbonate ions, and that contribute reductions of IOP or intraocular pressures. They usually administer twice a day. Systemic carbonic anhydrase inhibitors are used before going for any surgical resections. Coming to the adverse effect of CA inhibitor or carbonic anhydrase inhibitors, they include the myalgia, fatigue, nausea, loss of appetite, taste alterations, confusion, drowsiness, hearing dysfunctions, renal stone, and polyuria. So this drug is strictly contraindicated in hyponatremia, hypokalemia, severe kidney or liver dysfunctions as they precipitate the renal stone, and adrenal gland failure, Also, they are contraindicated in hypertonic alkalosis. Due to their teratogenic effect, they are also strictly contraindicated in pregnancy. So here the list of drugs they are contraindicated in glaucoma includes antimuscarinic drugs, include the atropine, hyoscine, and also synthetic substances. Drugs with the atropine-like actions like first generation antihistaminic drug like chlorpheniramine, dimenhydrinate, diphenhydramine, promethazines. Antiarrhythmic drugs, disopyramide, tricyclic antidepressants or TCA, promethazine, antipsychotics, corticosteroid or glucocorticoids like cortisol may also cause cataract. Different vasodilators like nitrates, phenoldiazepam, and succinylcholine being a depolarizing neurovascular blocker. So this list of drugs are strictly contraindicated in the patients of glaucoma, or they can precipitate the glaucoma.